Good evening, everybody, and welcome to this evening's Stress, Urinary Incontinence and Aiding Patient Decision-Making webinar. My name is Samantha, and I'm your host for this evening. Before we make a start, I just want to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. Alrighty, so I'd like to introduce our presenters for this evening. So we're joined by Dr. Jennifer King. Jenny is a urogynecologist and director of the pelvic floor unit at Westmead Hospital, chair of the Urogynecological Society of Australasia, and president of the Continence Foundation New South Wales. And we're also joined by Dr. Carmen Huckel-Schneider. So Carmen is a senior lecturer in health policy at the Menti Centre for Health Policy. Her field of research is health systems, governance, and policy development. Carmen's currently working with Health Consumers New South Wales, and through this she has listened to stories of hundreds of women with transvaginal mesh, and she's also a women's health representative for the New South Wales Transvaginal Mesh State Task Force. And our facilitator for the evening is Dr. Linda Mann. Linda is a fellow of the RACGP and a member of the RACGP Antenatal and Postnatal Specific Interest Network. Linda has local and international medical experience, especially in genetics and women's health. She's a GP representative on various national and local government committees and is an experienced medical educator. So thank you for joining us, and welcome Jenny, Carmen and Linda. Alrighty, I will hand over to Linda now to take us through our learning outcomes for this evening, and we will then hand over to Jenny King to commence the presentation.
By the end of this online activity, you should be able to discuss the public health issues regarding transvaginal mesh with patients in the context of the recent Senate inquiry, evaluate the range of management options available for stress urinary incontinence and their risk-benefit profile to support patient decision-making, and assist in patient-centred decision-making for the management of stress urinary incontinence, in reference to the International Patient Decision Aid Standards Collaboration Quality Criteria. I'll just add a note that we're not going to be discussing urge incontinence.
Alrighty, let's move on with the rest of the presentation.
Okay, what I thought we'd look at is, as a practitioner, what are we trying to do when someone comes to us with urinary incontinence? Now, obviously, the first thing, and we all think this, is we don't want to miss anything else that might be going on that's causing this woman to present with incontinence. We certainly don't want to miss anything that someone else is going to pick up in 6 months' time. So we do have to do a certain level of investigation. We want to improve her incontinence, and we want to stop it getting worse, but we don't want to go overboard. We don't want to spend half the health budget on a condition that can be managed conservatively in most cases. So what we need to do, and this is the basic stuff you do with anyone, we look at the type of their incontinence. What makes it better? What makes it worse? When did it start? Because what you're trying to get to is, could there be some other pathology there? Is there something in that story that doesn't look like, sound like simple stress incontinence? We're looking at the things that make it worse, because they're things we can potentially do something about. That means we can, most of the time, aim to manage that lady conservatively. It is important, Linda pointed out, we're not really talking about urge incontinence, but it's important to make the distinction between predominantly stress incontinence and urge incontinence, because there are different potential issues associated with them and different things that you have to be aware of, and very different management. So, for example, we know with stress incontinence, we've got our conservative management. If necessary, we've got surgical management. Rarely surgery has much to offer for patients with urge incontinence, and that's when we use medications. So just quickly going over what you will have come across so many times. The lady with the overactive bladder symptoms. Now, this isn't a diagnosis, it's just a symptom complex. It's the lady who says to you, when I've got to go, I've got to go. Everywhere she's going, she plans it by available toilets, and they know all the clean toilets in town. These are the ladies who say, I don't need to go to the toilet. I get to that front door and I put the key in and I'm busting, and they have to beat you out of the way to get down the hallway to the loo. Now, this tends to be a much worse type of incontinence than stress incontinence. It's unpredictable and it's variable volumes. It could be that if your bladder contracts inappropriately and you had 300 mils in there, you're going to be very wet. So it is a much more difficult type of leakage. Very common. It affects men, it affects children, and it particularly affects older ladies. And it's the third main reason that people are admitted to residential care when they get older. So clearly very important to deal with. But it's not the same as our ladies who come in and say, when I cough and sneeze, I'll leak. I've gone back to netball since I've had my children, or I get on the trampoline with the kids and my bladder leaks. It's a very much more predictable type of leakage, and you can pick what triggers it. Again, it is very common, probably 1 in 3 women. Interestingly, a goodly number of nulliparous patients. You'll get girls in their teens with sport, for example, particularly if they're carrying a little bit of weight. And what I found very interesting is 50% of elite athletes who take part in high impact sports will have stress incontinence. So we're basically badly designed. I always used to think that if you leaked playing sport, you'd stop. But in fact, if you're good enough, you keep going. And it's fascinating that they leak more in practice than they do in competition. And that's basically because of the adrenaline, which will remind us we've got alpha receptors in the urethra. So alpha blockers, as we'll come to later, can cause urinary incontinence. Okay, when we're going through their history, you can be sensible. If that lady walks in the room and she's fit as a fiddle and just tells you she leaks with netball, she's not going to have any complex neurological problem. So you don't need to go too exhaustively into that history. Again, you're just looking for red flags. You're looking for medications like alpha blockers for hypertension that might be precipitating her leakage. You're looking for other things that don't fit with simple stress incontinence. Ladies who tell you that they had retention after their baby and they put me in the bath and they gave me some pethidine. They tried to make my bladder work. That sort of patient may well have something very different going on. People who were bedwetters and had urgency and frequency in childhood, again, are likely to have an overactive bladder, not simple stress incontinence. Be careful of your ladies with any previous pelvic surgery because they could have a much more complex bladder. So they're the things that you're looking for when you go through the history, and you mostly won't find them. Again, examination. Don't miss other pathology. I would still get 1 or 2 ladies a year who have some pelvic mass that ideally should have been picked up earlier. And I think sometimes everyone finds it a bit embarrassing to talk about leaky bladders, and I think sometimes as doctors we find it difficult as well. So sometimes people don't volunteer information, or the doctors themselves think, look, I'll just get you to someone who deals with this all the time. But I would ask, in fact, that you do a few simple things with your examination. Make sure their tissues aren't atrophic. If they're postmenopausal with atrophic tissues, they need some estrogen. Make sure there's not significant prolapse because that will cause another set of bladder problems. You don't need to do extensive neurological examination, but just do a simple internal, get them to squeeze their muscles so you've got some idea whether they know how to work their pelvic floor muscles. Now, for patients with slightly complex symptoms, you may want to do more investigations. And again, these really are minimal. You basically want to make sure you're not missing something nasty in the bladder, particularly a cancer. So patients who say, look, I've had a 1-year history of pain when I wee, of frequency, urgency, day and night, think there could be something else going on. Most importantly, you want to exclude retention, and we'll talk about this a bit later, because that, if you think about it, if you have an overfull bladder which you can't empty, that could present in a whole lot of ways. You could have frequency because you can barely fit in another 50 or 100 mils before you need to go again. Or you could leak when you cough and sneeze simply because your bladder's overfull. So patients with voiding dysfunction won't necessarily give you a typical story. If you can get them to do a bladder diary, so it's a little record of everything you drink and everything you wee and when you wee, you can tell a lot from that. Having said that, it's very tedious and patients aren't keen on it. We certainly don't need to do urodynamics or cystoscopy in most patients presenting with simple incontinence. We keep them in reserve should they not respond. Now, I just wanted to make a little point about urinary retention. I often get sent people who've had an ultrasound for some other reason, excluding pelvic pathology, and the comment from the radiologist is they have a significant residual, they're not emptying their bladder properly, they need further investigation. Now, we all know if you sit in a waiting room with an overfull bladder for an hour because they're always running late, you do not empty your bladder very well immediately afterwards. So it's that over-distension can temporarily impair bladder emptying. And if that lady has no other symptoms of voiding dysfunction, she doesn't need further investigation. If you really are worried, you may need to do an in-out catheter or get your nurse to do an in-out catheter if you really think residuals are the issue. But I'd have to say, particularly in women, residual urine volumes tend to get overcalled. Okay, so we've worked out nothing much complicated seems to be going on. We're pretty sure it's just simple stress incontinence. So now we want to look at all of those things that could be making it worse and that we can change to improve the situation. And these are things that your continence nurses and physios will also work on with you. Estrogen, if they're hypoestrogenic, everyone needs estrogen in their pelvic floor. Vaginal estrogen is very safe. You will need to say 25 times, do not believe the package insert. Vaginal estrogen will not give you breast cancer. Vaginal estrogen will not give you strokes, but it does make a devil of a difference to your pelvic floor. Now, weight is another difficult issue. There's no doubt if everyone could lose weight, everyone's bladder would be better, but it's not easy. If it was, we'd all be skinny. Sometimes it's the little motivator that someone needs to get their bladder a little bit better. So mention it, but don't beat them over the head with it. Obviously, you smokers with your chronic cough, you can be as nasty to as you like, because anything that stops them smoking, whether it be motivation to fix their bladder, is worth it. Medication we talked about, particularly alpha blockers with stress incontinence, not much else, but some cardiac medications can affect urine output and retention. The lady who's endlessly lifting grandchildren, who's caring for an elderly partner, who's doing a lot of work, it will be difficult to get real improvement in her. And it's worthwhile saying you shouldn't be lifting like this. Let's look at what happens. And equally, constipation is another factor. Your bladder is always worse if you're constipated. So need to work on that one. Women who are postpartum, I would discourage from doing anything more than pelvic floor exercises. They will almost certainly improve with time, and you don't want to do anything drastic in young women with young children who quite possibly are having other babies. Okay, we've done what we can. We've decided to work conservatively with this lady, and we're going to send her off to a continence nurse or a physiotherapist. I don't believe any of us have the time to do all of this therapy ourselves, and I really encourage you to get 2 or 3 good nurses, continence nurses or physios that you can send your ladies to. They will encourage, they'll be their bladder trainer. They really will make a difference. Now, pelvic floor exercises, significant improvement in probably up to 70% of patients. They have to be motivated. If they're not going to do it, they're not going to do it. But at least you can say things like, even if you do end up with an operation, even if that's what you want, you're going to be better if you've got good pelvic floor muscle contraction. And you have to warn them that this takes time. You can't go to the gym and bulk up in anything under 6 months. Similarly, hypertrophy of your pelvic floor muscles will take up to 6 months, and you need to keep doing it. Now, there's lots of other little gadgets that your physiotherapist might have. Basically, all of these things are just ways of getting your pelvic floor muscles to work better. And of course, there's an app, and there's various little gadgets you can put into the vagina, and it tells you that you've squeezed better than you did the day before. And it's all forms of biofeedback. Basically, if they work for an individual, I think they're terrific. They all cost about $50 each, so it's not too bad. I think the message I would like to get across is make sure there's nothing else going on, nothing else that rings alarm bells, the red flags that make you think this is something else than simple stress incontinence. Patients with previous continence surgery, previous repair surgery could have a very complex bladder. Same as those with neurological disease. Send them off. They need urodynamic assessment because we need to know exactly what we're dealing with. And otherwise, you really only need to refer on those patients who've tried their best with conservative treatment, who really have put a lot of effort into it and are still majorly impacted. And quite honestly, if someone leaks once or twice a year when they have a bad cold, I don't think that warrants surgical management. We know what's causing it. You can put a pad on. Okay, maybe as the years go by, it's going to get worse, but we'll deal with it then. And I really think we need to encourage patients to work conservatively for as long as possible. Now, having said that, I am a surgeon and I do believe surgery has a place for those ladies. But I think, again, you need to be very careful about it. You will have heard a lot about the transvaginal mesh. Important to distinguish the mesh that we use for incontinence surgery and the mesh we use for prolapse. And I think probably been many more problems with the transvaginal mesh for prolapse than with the slings. Now, we know we're up to about 4 million midurethral slings worldwide. Australia's at 120, 125,000 slings since they were introduced. And we do have a lot of data on these. So I would have to say I feel very comfortable when patients have failed conservative treatment recommending surgery for. This is supported by most of the medical organisations. It hasn't been supported, obviously, by the parliamentarians, and you will have heard about that. But for me, as a doctor, I find this fairly reassuring. And I think you can say this to your patients. Look, you've tried really hard, you're still really wet. There is something else we can look at if you want to think about it. And the other thing to get very clear, there are complications with any sort of surgery. And we'll be talking later about better ways of getting this information across to patients. Now, you can get bleeding, infection, chronic pain with any operation. Our old operations, we had a 5% incidence of pubic symphysis pain and osteitis pubis, but basically we didn't have any treatment for those. We know that these newer midurethral slings have a much better safety profile than our older procedures, and they're as good or better without the same difficulties, for example, with voiding dysfunction. So now, the other thing is when you operate on a bladder, no matter what sort of operation you do, you can get problems. You can have problems emptying the bladder. You can make the bladder much more urgent. So instead of having leakage when you cough and sneeze, you've got leakage when you're busting to go. You can get recurrent urinary tract infections. And it was really interesting when I looked at the letters from the ladies at the Senate inquiry. So many of those had problems that were to do with their bladder function. And I think were a function of the surgery around the bladder. And I really think if we could have gotten to some of those ladies earlier, we could have made a difference, because this is an excessive number of complications really from any sort of continence surgery. There's no doubt there are problems specific to slings, and basically it's the nature of the mesh and it eroding into the urethra or the bladder. Now, that universally runs at about 1%. If I look at the ladies in Australia who sent in their letters, it's about 8%. So they've certainly had a disproportionately poor outcome. We get superficial mesh exposure. And that's when the lady might say, I can feel some scratching in the vagina, or her partner says, something's scratching me. And you can see that there's a little bit of mesh coming through the vaginal wall. Now, that's easy to trim off. It's the deeper erosions that are more complicated. Now, the other group where we've had problems is with a neurological pain post-operatively. And again, this happens with any sort of surgery. If you look at, say, breast surgery, including for malignancy, we've got about a 20% rate of chronic pain afterwards. So it's not that it's unknown, but for the ladies who've had a sling procedure, what you've got to remember is they had a non-life-threatening condition and they now have a serious complication. So it's very hard to balance that. It may be that we will be better at predicting who may be at risk of pain following these sorts of operations. And certainly it looks like those, for example, with fibromyalgia or chronic bladder pain, chronic pelvic pain are a high-risk group. So I think we have to be super, super careful there. But basically, if you've got a lady who's really tried very hard, and quite honestly, that incontinence is driving her insane, I don't think it's unreasonable to refer her for consideration of surgery. But don't she doesn't have to come with the first bit of leaking. We all need to try and say, look, this is not a major drama. It's not going to cause problems. It's better that we manage conservatively as long as we can. Then if we need to look at surgery, fair enough. So that, I think, is the focus that we need to go with. Thank you.
Thank you. So I guess I get to take over for the next few minutes at this point. I am going to give a bit of a background to how we've come to this point, and what I'm going to be talking about over the next 15 minutes or so has been informed by taking a systems perspective about how we've got to where we are now in the discussion around treatment of women for stress urinary incontinence, as well as reflecting on the conversations that I've been able to have in my work with women who have reflected on their own experience and treatment for stress urinary incontinence, frequently with women who have had surgery and later come to regret it and wish that they'd had a different pathway of care. So how did we get to this point now? So on the slide here, you see just a few of the things that are happening around at the system level that have meant that we have an increased focus on conservative management for stress urinary incontinence and how to encourage that in the system. You're probably all very aware that there's been a series of parliamentary inquiries. There's been one in Australia, one in Scotland, and there's currently something called a safety review going on in the UK at the moment. It's been a very interesting experience observing these parliamentary inquiries. They were initiated by consumers and consumer concern and consumers going to their parliamentarians asking for these inquiries.
Carmen, can you just remind us what POP and SUI stand for?
Yes, certainly. So these parliamentary inquiries have looked into the types of surgery that use mesh for pelvic organ prolapse, PUP, as well as SUI, stress urinary incontinence. And as Jenny said before, although the material is the same, the mesh devices used to treat pelvic organ prolapse and stress urinary incontinence have a different anatomical function. They're also placed differently. It's a different type of surgery. And generally, the devices used for stress urinary incontinence, which is also known as a mid-urethral sling, or sometimes goes as a tape and sometimes goes as various different brand type names such as TVT or TVTO, are a smaller piece of mesh device which is placed to support the urethra, as opposed to pop mesh, which is placed to support organs that are prolapsing, hence pelvic organ prolapse. So these parliamentary inquiries have taken place and they've been looking at both of those different types of devices. And you may be aware that one of the conclusions from the Australian inquiry, which had a final report passed down in March of 2018, was that transvaginal mesh implantation should only be undertaken with fully informed consent and as a last resort when other treatment options have been exhausted. So this is very much what we're talking about today. What we've also been seeing happening is that there has been action by consumers, for consumers and amongst consumers. There are a range of consumer forums. There is an organisation, the logo of which I've got up there on the slide, Mesh Injured Australia, which is an organisation that's been formed by women who have mesh implants, who are advocating for better controls and oversight and transparency at the TGA in terms of the regulation of devices. And also, as part of that Senate inquiry, the Health Issues Centre and the other state consumer peak bodies opened up a survey asking women about their experiences, and they were surprised that over 2,000 women in Australia responded to that with stories of their experience with transvaginal mesh. Overwhelmingly, those stories are partly focused on the adverse outcomes that they've had after their particular surgery, but also overwhelmingly it's about the process of care, what they went through in the lead up to having surgery and what happened after they've had surgery. They're very much focused on, I wish I had known more, I wish my GP had talked to me more, I wish I'd understood more about my different options. And I wish that I had had a relationship with someone so that I could talk more openly about my stress urinary incontinence, and I think that I probably would have taken a different path if I had been able to do that. There have been some outcomes from those reviews. There's been the suspension of the use of mesh for pelvic organ prolapse in Australia, only now being used under certain special permission conditions, and also a type of the mid-urethral sling called a mini sling, which is basically a shorter version of the mid-urethral sling that has an anchorage. So there's a different mechanism through which the device is fixed in place. They are currently under special access arrangements only. This is all happening in a contextual backdrop where there is continual scrutiny and criticism of device regulation more broadly. The Therapeutic Goods Administration rules that are in place for regulation of devices are quite different than the way that evidence is assessed and devices are regulated, or there's regulation of pharmaceuticals, and there is a political move to make those standards more similar to the standards that we have for pharmaceuticals. So that's all part of the backdrop of that. There are a range of evidence gaps which are being discussed amongst administrators, but also amongst epidemiologists and in systematic reviews. We know that there are some gaps in terms of longer term evidence, but particularly we still have gaps in terms of being able to recognise which patients are more well suited for surgery than others, and which patients might be more likely to have complications than others. We have a systematic review that was released in 2017, directly prior to several other larger studies actually coming out. And so we are eagerly awaiting a review of guidelines from NICE in the UK, which is expected earlier next year, which will be able to bring together the latest evidence on that again. You may have heard that in the United Kingdom, currently there's a suspension on the use of the mid-urethral slings. It's not suspended in Australia, but there's currently that suspension that is pending the safety review that's happening there at the moment. Probably also aware that there are various different class actions that are happening. Consumers are currently in legal action against manufacturers of various devices. That's kind of running parallel, and it all forms part of this broader noise that we've got around the use of devices for stress urinary incontinence and POP at the moment. And we've also then had various different policy responses to the Senate inquiry. There's a transvaginal mesh clinic which is currently being piloted in New South Wales at the RPAH, and there is some action in other states as well, as there is an increasing demand or expected demand amongst patients to have corrective surgery following the insertion of mid-urethral slings. So these are all things that your patients may or may not be aware of, but it means there are certain things to be looking out for. There are a couple of quite prominent voices that have been discussing in the various parliamentary inquiries and in the various different safety reviews about why we've got to the situation where we've got to now, where there is so much noise, where there is so much policy action at the moment. The Professor for Evidence-Based Medicine at the University of Oxford has been an advocate for the current suspension of the use of mesh surgery in the UK. He discusses there this combination of the fact that we've got doubts over the way that medical devices more broadly are being regulated, as well as certain gaps in the evidence about who or who isn't suitable for surgery that is leading to this situation. And we also have a urogynecologist from Scotland who's been quite prominent, and he often talks about how when we're thinking about potential risk of surgery, the fact that mid-urethral slings are a permanent device really sticks out to him as to a reason why he thinks so many women are now very, very concerned about having the devices inserted. But as I said, from the conversations that I've had with women, the real focus amongst them is more about their journey and their care and their relationships with clinicians along the way, and how they wish they'd have a better partnership, more in-depth conversation, more knowledge and more open discussion about their choices. And if they had ended up with, after a good relationship with the clinician, still making the choice to have surgery, that they would have accepted the risk of complications if they'd really known that they were making the choices with their full discussion, knowledge that they wish that they had had. So like I said, there has been some policy actions that have happened more recently. There is a series of patient information sheets that have been produced by the Australian Commission of Safety and Quality in Healthcare. Also a clinical pathway for stress urinary incontinence and incontinence that I'll be putting up on the slide in just a minute. And some credentialing guidance has been distributed to local health districts in New South Wales. New South Wales Health, as well as various other health departments in other states, are engaging with women who have had injuries and have been unsatisfied with their treatment in developing new policy actions as well. So I'm going to, throughout the remaining 10 minutes, put up a few of, just a few bubbles of quotes that have come from women that I've been speaking to as part of the work that I've been doing, just to give you a bit of an indication of what they're thinking when they're reflecting on that early part of their journey, where they might have had the option to extend or try conservative treatment a little bit longer. This woman said to me, in that 10-minute visit, and by that she means with the GP, in which they note your symptoms and scribble off a referral, the very real life of a woman, mother, wife, is possibly about to be altered forever by the course of treatment that they recommend. And women often said to me that they felt that by the time that they had reached the point of referral or speaking to a urogynecologist, that they had basically had a decision made for them, that they were then down the pathway towards surgery. And we want to make sure that they don't feel pressure or that decisions have been made for them, but decisions are being made with them. So what all of this background and system changes means for GPs is that there is going to be a greater focus on management of stress urinary incontinence in the primary care setting prior to referral and prior to surgical management. So do watch out for the emergence of shared decision-making guidelines, which will be coming out probably over the next 12 months or so. Updated guidelines from NICE in the UK. It's been delayed, but it's expected in 2019. Better guidance for patient selection as we gather and compile the evidence on who is more suitable for what kind of surgery. And an increased focus on management of stress urinary incontinence as a chronic condition in the primary care setting, extending that period of conservative management. So this consumer wrote, they're the ones who write the referral to the gynecologist. These referrals are often written without much thought, but what they don't realise is by the time a patient gets to a specialist, the patient feels they've already had 2 doctors confirm their need for surgery. So this is a sentiment from one consumer. It's not a representation of everyone's experience, but this particular woman definitely felt like they wanted more from the GP, more time before they got to the referral stage. So on the screen now is the urinary incontinence care pathway that's been developed by the Australian Commission for Safety and Quality in Healthcare. We have the link down at the bottom of that slide as well. So I'm sure you'll all be able to, I mean, it's a fairly clear pathway that you'll all be quite familiar with. And what I would really like to emphasise is that women want to have time to go through this pathway and through this journey. When they look back, many women have said to me, you know, it really wasn't that bad. I really didn't give enough time to trying the different options. I wish I knew what the different options were. I didn't have time to discuss or go through the different options that were available to me. And the one quote that's there on the right side is actually from the Senate inquiry report that says they were struck by, so the parliamentarians that led the inquiry were struck by the personal accounts of women who wrote to the inquiry generally did not reflect a process of thorough counselling and informed consent. And this is what really needs to start already in the primary care phase. It doesn't just happen when you are already along the pathway towards surgery, but counselling and informed consent starts very early in the process. So in this pathway, we have various different elements, some of which are really quite clear and that in your own practice you may be doing already or feel very comfortable doing. So the bits about working out when the patient actually leaks, how long has it been occurring, the quantity of the leakage, the general health assessment, the urinary symptom assessment, and distinguishing between the different types of incontinence. There's also the very technical parts of the guideline, many of those which Jenny already went through with you, working out when it is a situation of so-called complicated incontinence, recurrent, debilitating, severe incontinence, making sure that you're not missing those other pathologies that we need to be taking notice of. And also various parts of the first line management are also quite technical and you can work through those. But then we have certain parts of the care pathway which really are those challenging parts, and it's those challenging parts that women that I speak to say that they wish had been done better in their instance. That's answering questions such as how bothersome is the incontinence for that particular patient? Am I really working through different lifestyle interventions and actually reviewing that management? So how bothersome, what is their quality of life? What is their actual desire for treatment? Working through those lifestyle interventions and reviewing that management. And those are the four aspects that we would really like to emphasise in this session that we need to spend more time focusing on. So we can go back to our dimensions of patient-centred care in order to bring about and remember what it means to spend time with patients, focusing on those difficult parts of that care pathway, working out how bothersome is it, what is the desire for treatment, working with that patient and developing that relationship. So creating a fabric of trust, beginning with listening, promoting that clear, empathetic communication, tailoring it to patients' needs and their abilities, and getting to know the patient. Because if we are going to be focusing on more conservative management in primary care, it does mean developing a relationship with that patient as they may be working through a period of several years of trying conservative treatment, adjusting their lifestyle, working out to what extent do we need to adjust your lifestyle, what can you live with, what can you change about your life, what can you fix with conservative management, and what different steps will you try before we move on to referral and potential surgery. So things such as how bothersome is the incontinence for the patient and assessing the quality of life and desire for treatment. Some simple rules that we can draw out from the patient-centred guidelines: listens to patients, question your own assumptions about what you think might be bothersome or might not be bothersome for that patient. Reassuring the patient that stress urinary incontinence is quite common, especially after childbirth, so they don't feel that it is unusual or that they are alone. You can reassure patients that the majority of women who do have stress urinary incontinence do manage their condition without surgery. There are far more women with stress urinary incontinence than women that have had surgery. Patients might not want active treatment now, but a lot of patients say that they feel like they have to continue to talk about it because they don't want to be forgotten. So if you're reassuring the patient that we don't have to do anything now, you can come back later, months' time, 6 months' time, in years' time, and we can do something about it then. So the patient might be pressured to make quick decisions if they're already ending up in front of a specialist. It might be due to the cost of appointments. It might be due to feeling like they're further along the pathway to surgery and they've already been told that that's the direction in which they're going in. So reassuring patients that they can try something at a later time. They can come back and try something at a later time. I've just got an excerpt from the current NICE guidelines there. So if a woman chooses not to have further treatment for incontinence, you can offer her advice about managing those symptoms, and explains that if she changes her mind at a later date, she can book a review appointment and discuss past tests, interventions, and reconsider the treatment options at a later time. There are also different resources out there about offering advice about managing urinary symptoms. So there are various different strategies, obviously, for trying to alleviate the symptoms of stress urinary incontinence, and that includes getting the chronic cough under control. That includes good bladder health, good bowel health, getting straining and any issues about toileting under control. But there's also a lot of strategies about planning everyday life and adjusting everyday life. And I have listened to a lot of women who said, it was mild enough. I wish now that I had accepted that I had moved into a new phase of life and that I just needed to adjust the way that I live so that I can live with my stress urinary incontinence. We have on the screen here a few of the self-management resources that are out there. There's a really good resource from the Australian Federal Department of Health on What Now, helping clients live positively with urinary incontinence. I suggest that everyone read that, but there are various different resources available from the Continence Foundation of Australia, as well as some good resources about healthy bladder and bowel habits. And engaging in this conversation with women is all about relaxing the experience of being able to talk about having stress urinary incontinence, emphasising that it is common, that there are a lot of different things that we can do. Their life certainly isn't over, and we don't have to do anything drastic about it now, and that you're with that patient for the long haul and the long journey as they decide to discuss their different choices. In terms of a review of management, once again, it is about listening to the patient's journey with respect to attempting each of the different management strategies. They might be doing several concurrently, or they might decide one thing after the other. Long-term encouragement to keep pursuing lifestyle change, and a lot of the lifestyle changes that can help with stress urinary incontinence are also those that help with other aspects of healthy living as well, particularly related to smoking, good bowel habits, good bladder habits, and losing weight if the patient is overweight. Ensuring that there's a safe, non-threatening, non-judgmental discussion, and explaining the importance to have made good, full, genuine attempts at management before proceeding to surgery. Just pulling up here some of the dimensions from the International Patient Decision Aid Standards Collaboration. So there has been a lot of talk about consent processes having been inadequate in the lead up to surgery for incontinence as well as pelvic organ prolapse. So keeping these different dimensions of good patient joint decision making in mind will help us ensure that women move through their journey having the sense and the feeling that they've had a good relationship and have been in control of their own particular choices. So that means with any of the different choices that we're discussing with patients, we need to describe the health condition or the problem for which the patient decision is required. So they need to understand what they've got and what they're making a decision about. We need to clearly explain to patients what each of their choices are at their particular point in their journey, describing those different options that are available for the decision, including non-treatment as an option where it's appropriate. Different positive features for each option, that includes risks and benefits of each option, the negative features and the relative risks of each option. And thinking about discussing with the patient what is important for them, what are their different values, what are the outcomes that they're looking for, what is important for them, how do they understand potential risks, potential benefits, and encourage them to discuss what's going through their mind. What are the different options that they're weighing up? Why are they choosing one option over another? What is too difficult for them? What is easy for them? What would they like to keep on trying? There is one patient decision resource that is available for patients that are potentially leading up to the journey of referral and potential surgery for stress and urinary incontinence. I like this one in particular because it includes a particular table on the page that you can see on the screen here that asks patients to articulate their choice. Why do they choose the option that they're choosing? And can they justify, give reasons for the options that they're choosing? I'm not saying this is necessarily the best patient decision aid to be using, but I quite like to emphasise that part of the procedure of informed consent is going through the journey, knowing their different options and being able to articulate why a patient chooses the option that they want. And we want that right from the point of being early on in their journey. So GPs have a key role in optimising that conservative management for women with stress urinary incontinence and understanding those patient values and ensuring that their journey in treatment starts with a discussion very early on about all of their different options and being able to reason why they choose their different options.
We've got some questions that you might like to make some comments about, both Carmen and Jenny. People have asked about access to publicly funded allied health bladder folk, both urinary continence nurses, pelvic physiotherapists and the like. And there's an impassioned comment from someone in southwestern Sydney. Do you have ideas about how people can access these things?
Most of your public hospitals will have continence physiotherapy services. We do have a shortage of continence nurses because they're so under-resourced. They spend their time with catheters in the community, but all of the public hospitals have a physiotherapy service. The problem is your wait list is easily 6 months. There are private physiotherapists. If you go onto the Australian Physiotherapy website, they'll list their women's health physiotherapists. Now, that could be a cost factor, particularly in southwest Sydney. And I don't know how you have a system, don't you, where patients can get physiotherapy, but I'm not sure if that applies to people who aren't elderly or, you know, if there are limits on it.
The requirement is that the person has a chronic condition which has been present for longer than 6 months and that there are 2 allied health people plus the GP involved in their care.
So that could work for quite a few, couldn't it?
Yep.
Yeah. So definitely, if you can get your patients to private physios, they'll get perfectly good service. It's just the cost if they need ongoing treatment. But try your public hospital first. We want people to put pressure on New South Wales Health that we need a lot more resources in the community and in the hospitals for conservative management. So don't worry about complaining. You're actually doing me a service.
And also for women that are still experiencing a certain level of incontinence after the birth of children, tapping back into the hospital where they may have birthed their child, they may be able to still see a postnatal incontinence nurse or a postnatal physiotherapy related to the care that they've had in their hospital. So that's also one avenue to look out for your patients.
Carmen, in the planned resources, are women for whom English is not their first language going to be accommodated?
To be honest, I find the resources out of the UK and the NHS to be better in that than the resources out of Australia. The plan is to make resources available in multiple languages, but the care pathway resource for GPs is still currently only available in English, and the Commission is still in the process of providing any other languages as well. So we're still reliant on our other translation services, but that's a clear message that we want to send back to both the Commission for Safety and Quality in Healthcare and the various different state authorities. Yeah.
And how do you think GPs, apart from the people who attend this webinar, will get access to these guidelines? New South Wales Health, for example, isn't the best at connecting to general practice. Are there other resources that you think would be a repository for this information? I don't know, like Health Pathways perhaps?
Yes, so Health Pathways is available in some of the primary health networks these days. and linking these resources into health pathways is something that the task force is going to be looking at, so that each of the health pathways where they are available in the primary health networks will be linked into those resources. The guidelines and information sheets that are available for consumers can be accessed direct from the Australian Commission for Safety and Quality website, and New South Wales. I know that in New South Wales, because that's where I'm located, there will be additional resources for GPs made available in approximately within the next 6 months. But integrating it into a more sophisticated care pathway into health pathways is something that I'll be encouraging all of the primary health networks to do now that we have that care pathway that I went through in this webinar.
And of course, it'd be wonderful if the manufacturers of software would include these things in the patient information that's contained in the software, but that would mean they'd have to spend some money. So I guess that's probably not going to happen.
There is one other possible avenue for translated pamphlets. The International Urogynecology Society Association has most of their patient information leaflets online, freely downloadable, and many of those have been translated. So it's IUGA.
Yeah. So one of my favourites is actually one produced by the NHS. When we're talking about the tape procedures, it's actually released in the middle of last year. It has a really, really good breakdown of issues for consumers and different options for conservative management, as well as the different options in terms of surgery. And I do think that we've still got a little bit of catching up to do in terms of the official resources that we'll make available in Australia, but it is going to all be happening over the next 12 months.
Great, so that does bring us to the end. So if we jump on the next slide, you'll be able to see the learning outcomes again. So this is just a review of what we went over at the beginning. Linda, did you have anything else that you wanted to add in terms of the learning outcomes or what we've covered tonight?
I think the thing for us to remember is the fact that we were talking about stress incontinence and not talking about the other sort. Patients often like an easy medical fix. And I think one of the things we've learnt tonight is, in fact, we GPs have a job to do in supporting patients over a long period of time to change their expectations, because if they jump for the quick fix, which might be a surgical one, they may end up ruining the day.
Fantastic. So that does bring us to the end of this evening's session, and I would just like to say a big thank you to our presenters, Jenny and Carmen, and to our facilitator, Linda. Thank you for joining us tonight, and also thank you for everyone that joined us online as well.